Today I truly feel privileged to introduce today's guest speaker, Dr. Vinay Sharma, consultant obstetrics and gynecologist at the Leeds Teaching Hospital, National Health Services Trust, and Centre for Reproductive Medicine, Singh Hospital, Leeds. Dr. Vinay have been a brilliant and meritorious, well-decorated undergrad student. For undergrad, I just wish to convey that she stood first in the university among girls in pre-medical examination held in 1971 of Haryana state, and with a fifth overall position in pre-medical examination of 71. During her medical education, she earned silver medal in anatomy, second prize in physiology, bronze medal in medicine, and she also earned gold medal being the best graduate of the session 1971-76, in addition to the certificate of merit. She also got gold medal in general surgery, silver medal in general medicine, and many other subjects to her credit. After graduation in 1976, she did DCH in 1979, MRCOG in 1984, FRCOG in 1977, and completed her PhD in 1995. Further, she has been the Yorkshire Woman of the Year in career category in 1995. She received honorary PhD from Leeds Metropolitan University in 1997 and has been independent member of the Board of Governors of Leeds Metropolitan University for a decade, that's 10 years, from 1997 to 2007. She has been president of North England Society of Obstetrician and Gynaecologist in the year 2012 and 13. She has been the Human Fertilization and Embryology Authority person responsible until April 2005 and an obstetrician with over 5,000 maternities annually. She has pioneered in ambulatory ultrasound-based ART, assisted reproductive techniques, and have established ART units at the Singapore General Hospital and Thomson Medical Centre in the year 1987 and 88. She also prepared protocols for Leeds Centre for Reproductive Medicine She has been assessor of Royal College of Obstetrics and Gynecology for failing service, and she has published over 62 scientific research papers in various journals of repute, and have conducted 38 research trials of various kinds. She has also presented more than 170 papers in various conferences and workshops, which have been duly abstracted and have been presented in the form of poster presentation too. She has been an excellent teacher and has played a substantial role as clinically active human fertilization and embryology authority person responsible at Leeds Centre for Reproductive Medicine from 2010 onwards, and have trained 31 subspecialists in reproductive medicine. One of his trainees is currently professor, and the other one is a reader in obstetrics and gynecology, and 18 of them are working in National Health Services as consultants. She has contributed 50% of the cost of chair in reproductive biology in Leeds University, and has contributed £5 million annually to the Super Regional Service Provider Trust budgets. She received research grants for 10 research projects on various research topics. In addition to, she had 7 collaborative research projects. She has supervised 8 MD and PhD thesis projects. Thus, her contribution in medical sciences is significantly appreciated, and the medical fraternity of this country feels pride on her contribution to medical sciences. Now I request to invite Dr. Vinay Sharma for the lecture. Thank you.
Dr. Prem Singh, Dr. Dilip Singh, Dr. Kohli, and my friend Professor Singhla. I think I've made it if I come to a university where my classmate is the Vice Chancellor. So this is my claim to fame. Everything else you can believe or not believe, it doesn't matter. But this is it. I qualified as an obstetrician and gynecologist, but I gave up obstetrics in 2007. This has been the nature of evolving medicine in the West in particular, but it's, I think, the case here too. You become a specialist in a certain area and you try not to be the jack of many trades. And having concentrated on gynecology, then get more and more concentrated, probably boxed in, but concentrated in reproductive medicine and surgery, which has been my area of specialism. I still am the HFA person responsible, which means I hold certain regulatory responsibilities, and I'll come to those in a minute, because I included, which I thought might be useful for evolving medical scene in India, the governance aspects of working in this field. So working in fertility, the fact is that about 1 in 4 couples, as per WHO, will suffer from subfertility at some stage in their lives. According to ASHRAE 2014, and that does not include India, because we don't have any national organization which is controlling, regulating, or counting the number of cycles that are being performed. So this is only from countries where there is a national structure and where there is a statutory obligation to inform the government or the regulating body of any treatment that you conduct. So as per that, more than 750,000 ART, artificial reproductive technology cycles, have been held globally in 2014, and 60% of those actually require ICSI. Reproductive medicine and surgery per se has many aspects, and as I've already said, I'll concentrate a little bit on science, which is my first part of my talk, and regulation on the second part, and I'm not going to talk about surgery. That can be a subject of another speak at some point. So, what does Tuesday the 25th of July 1978 mean to us in reproductive medicine? It is a day when in this very small hospital in Oldham, not too far away from where I live and work, about 100 miles, Oldham, where lovely Louise was born, and Steptoe Edwards announced to the world the birth of this first test tube baby child. She is now 36, has parented a child herself. The institution, as you saw in the previous slide, has changed substantially. And the pioneers are all long gone too. Steptoe, who was the gynecologist and brought laparoscopy to the United Kingdom also, went very early on in 1988, but Edwards lived to be decorated with the Nobel Peace Prize last year. Unfortunately, he died of Alzheimer's, as ultimately everybody gets hit by old age. But not before he left an enormous legacy. Procreation is the most innate desire of any mammal. And even when you are in a country, an overpopulous country like India, you would still want to have your own children. That is an absolute necessity. It's part and parcel of our social structure. So treatments for infertility gave hope to millions of people, but they also inspired a lot of fear. It was an awesome development that energized quite a lot of excitement, but also created a lot of fear amongst the ethicists who thought that doctors were suddenly going to act as gods. And that was the case, of course. If not regulated, that would still be the case. Science was obviously very excited. It gave entry to an absolutely brave new world, and we thought we were on the verge of something very big. I was still doing pediatrics at that time, not in gynecology. That's a different story. But we moved from, in early 1990s, from simple insemination of the eggs to sperm injection inside the eggs, which is the ICSI procedure, and creation of embryos, and thus treatment for male infertility and many other conditions for which we do not or did not have treatments before with IVF came into being too. And now we moved into spindle transfer, which is theoretically a treatment for ageism, but is not approved for this purpose within the United Kingdom. It is being used in the US for this purpose. And essentially it involves removing the spindle of a mature egg, because that's where the nuclear DNA sits, and taking that from a younger egg and transposing it or injecting it inside the spindle-less egg from the recipient. So the recipient is still contributing all the mitochondrial DNA, 70% of which, well, in fact, 100% of which comes from the mother. So the mother is still contributing the mitochondrial DNA and is responsible for 70% of our well-being or illnesses that we develop in life. And that nucleus then allows the egg to behave a little bit more in a younger fashion. So that's the spindle transfer. This is a picture of a mitochondrium within the ooplasm, and these mitochondria are scattered all around, everywhere within the egg. And these can be removed and transposed as well. And Britain became, this year, the first country in the world to license mitochondrial transfer for genetic disease. And this essentially involves taking a mother's egg, mother's nuclear DNA, and moving it into a recipient egg, which has been, from where the donor's nucleus has been removed. So the donor's nuclear DNA has been taken away, the mother's DNA comes in, and we now have two mothers, effectively, one contributing the mitochondrial DNA without disease, and the other contributing the nuclear DNA so that she can have her own genetic child, which gives certain characteristics, obviously, that we see in our own children. And this is how a mature egg, a new mature egg develops, which can then be used with the ICSI procedure, as in a picture shown before, for creation of embryos. And this is the first approved way of dealing with genetic disease now. So reproductive medicine has now moved on from treatment of infertility into a much larger field of pre-implantation genetic diagnosis of embryos for genetic disease and treatment and alleviation of disease before it happens. To conduct this effectively, we need to have an understanding of physiology and how the follicles develop. It has been evident that maternal contribution to oocyte quality is the key. It is the essential key to success, and if you do not perform this part of the process well, then you are unlikely to have a successful outcome. And we, of course, manipulate the gonadotrophins all the time. So the next part of my talk, still part of the scientific section, is to do with folliculogenesis, and I'm sorry if anybody gets bored, but I'll try and rush through that if it is not interesting. So gonadotrophin, the follicular development phase itself is about 3 to 4 months, but only the last 2 weeks are in control. And earlier on, somebody was discussing with me about the possibility of conserving eggs. You cannot conserve eggs, and you'll see that information in a few minutes. The first 3 months are gonadotrophin independent progression, and if you perform research studies, you hypovisect mice or rodents, or you create knockout mice where you have taken out the FSH beta receptor or FSH receptor gene, or you have inactivated the FSHR gene, mutated it, you will develop premature ovarian failure because the oocytes are continually still being utilized and finished with. So only the last 2 weeks are used. In the ovary at any particular time, you have oocytes in all stages of development. So you have the primordial oocytes, the primary oocytes, and then you have the antrum formation and the protoproducing. And during this 3 to 4 months of journey, we have exposure to a number of instructional and nutritional signals to which the egg is exposed to, and these are the ones which are subject to manipulation in order to create good gametes, in order to create good embryos for a good outcome. And then we have steroid and growth differentiation factors, which has been the area of my research interest in the last 10-15 years, and then intermediary metabolites as well. So gonadotrophin independent phase, which is the primordial to the primary stage, is primarily controlled by the activins. The FSH comes in. It is essential for the development of the antrum and conversion of the primary to the secondary tertiary follicles. Otherwise, these eggs will develop and they will die. All women will develop premature menopause, even if they took the oral contraceptive pill for their entire productive life and didn't menstruate naturally and didn't ovulate even once in their entire life. So that's important to remember. Activins have an important role. They enhance the granulosa cell activity, promote FSH sensitivity, and it induces the antigen synthesis. This is important for folliculogenesis and gets converted into the latter stage of follicular phase into inhibins, which then promote androgens, and this is synergized with the FSH. Moving on from there, I think I've again going through this very quickly. Primordial follicle becomes the primary follicle as the granulosa cell stratifies, and as the secondary follicle develops the theca interna. And we then have the antrum formation and the Graafian follicle formation, which is then the one that is ovulated. So again, graphically presenting this, there's an FSH threshold. The level has to rise above the threshold for follicular recruitment to take place. Otherwise, there are waves of follicles continually developing and dying. As soon as the aromatase activity is acquired, which is the steroid biosynthetic activity that is acquired by the granulosa cells, the FSH levels will fall through the negative feedback effect on the hypothalamus. It's the same process for thyroids, same process for the adrenals, and as the FSH level falls, the follicular recruitment will then stop, and the further waves will continue to die, but the one that has the FSH receptors and aromatase activity will continue developing and will develop a dominant follicle. Within the ovary, there is a two-cell system. There is the theca cells, which respond to the LH and produce the androgens, and these are taken up by the granulosa cells and through the aromatase activity converted into estrogens, and these again would have that negative feedback effect on the hypothalamus. The FSH proliferation occurs under the influence of FSH receptors. But what is important to know, and very important to know, is in this orchestra, in this symphony, the oocyte is the conductor. He is the master, or she's the master. All eggs are X actually. That was a sexist remark, sorry. So we have, this is the oocyte, and it has microvilli that cross the zona pellucida. And then we have the granulosa cells, which also have microvilli, and they also cross the granulosa pellucida, and they interdigitate with each other, and mRNA transfer can be seen from the mother to the egg, and from the egg to the mother. And this is how the egg controls how the granulosa cells and the follicle develops around it. and how the granulosa cell development and its environment affects the quality effect that develops. And this is the enigma. This is how we have to deal with metabolic issues associated with polycystic ovaries, or with raised BMI, or with endocrine, other endocrine issues such as hypothyroidism, vitamin D deficiency, all those things, in order to ensure that the oocyte development is not compromised. But the oocyte has to be good and capable to start with in order to develop that to start with as well. So there we are. We have these gap junctions which develop a dialogue between the tubular cells and the oocyte and influence the metabolism of the follicle. This slide looks complex, but the only message that I want to give from here is that there are pro-apoptotic features. Now, apoptosis is the term used for pre-programmed cell death. Every cell that develops in the body has its limited life and will undergo pre-programmed atresia and will spend its life and do that. So no cell can live forever. And the survival of the human milieu is a balance between the pro and the anti-apoptotic features. And this is no more or better visible than in the oocyte itself. I think I'll skip this slide just in case it's a little too complex, but important to realize here is that the oocyte produces this BMP15 and BMP6, which is anti-apoptotic, and ensures its survival, and it ensures that the cells around it are also surviving because they are the ones which are producing the estrogens in order for it to survive. So it is a symbiotic relationship. And same is true for GDF9. And when there is dysfunction or dysregulation, like with GDF9 or with the BMP15, here in the first column, here you see a normal ovary with GDF9 production, and the third column again, a normal ovary with BMP15 production, and here you see a PCOS ovary and you have none of these two. So this dysregulation means that the oocyte development is compromised, and that is a consequence of either oocyte malfunction or the metabolic changes of the woman. Again, mutation of certain genes will lead to premature ovarian failure, and BMP15 is the most important one in there. LH is very important. I've said a lot about FSH, but it has many roles. It's anti-apoptotic, it stimulates the theca cells, the androgens, which are very important. It acts in synergy with IGF-1, which is very important in initiation and recruitment of the follicles, upregulates the growth factors, and angiogenesis, which is ensuring that the blood supply of the follicle is maintained. For good oxygenation, hypoxia within the follicles compromises the oocyte quality, and there is an improved responsiveness of the oocyte. So this is just to say the same thing again. So there is an LH therapeutic window. Too much or too little is bad. There is a ceiling effect. LH threshold needs to be above 1.2. If it is less than that and you have a hypogonadotrophic woman, then you would have impaired follicular growth, you'll have impaired oocyte maturation, and inadequate androgen and estrogen synthesis. If you have excess LH, as you would see in women with hyperandrogenism, and you would have follicular atresia, oocyte development is compromised, and granulosa cell proliferation is suppressed, and premature organization occurs. So we spend our life ensuring that the LH is maintained in optimum range, not too little, not too much, and we use various methods, antagonists and GnRH agonists and antagonists to achieve that purpose. Oocyte quality and maternal contribution is one of the most important features of success. Age has an important feature or very important impact on the oocyte quality itself, and this is because there is gene polymorphisms develop as we get older. The secreting capacity for androgens goes down, the LH receptors go down, the LH capacity goes down, there's reduced paracrine activity, and there is reduced vascularity. Our vessels become atherosclerotic, and you have relative hypoxia, and you have decreased mitochondrial energy production. So the oocyte quality goes down as women get older. Here in one on the right hand side you see this particular egg which is young, and you can see just using the BRCA1 gene how densely populated this egg is with this BRCA1 gene, and then you see an older egg and you see that the gene loss has occurred to a significant magnitude. So this is the impact of age, and oxidative stress occurs as a consequence. So fecundity, ability to treat, or ability for a woman to become pregnant progressively goes down as you get older. And you can see that there is a very, very steep decline once you cross 35. And that's why timely intervention is very important. And one of the things that I see commonly in my practice amongst Asian patients is that IVF is left very much to the last resort. It is not. It is timely and appropriate intervention, which is the most important one, and it's never the last resort, because even then it won't succeed either. The number of eggs available progressively go down, and with IVF, even when you have good morphology embryos in older age groups, the risk of aneuploidy, chromosome abnormality, is substantially increased, and that is what is responsible for this very steep decline in success rate of IVF beyond the age of 35, and you can see above the age of 40 and 42, we have very little success, but we can obtain very good successes with donor eggs. Even from the age of 28 onwards, you can see you have better success rate with younger women. So age is an important contributor to the likelihood of success. Here, it may be too scientific for this audience, but I'll just run through these. The slides are here. And this is what we have been doing in the last 10 years. We collect the eggs, we collect the follicular fluid in a trap. That fluid is examined under the microscope to see if there's an egg there. And that egg is numbered, the follicle is numbered, the follicular fluid is collected and isolated and assessed in a laboratory for various cytokines, and we can monitor the fate of the egg to the point of birth of a child. So this is how you can see, you can study the follicular milieu, because each egg and follicle is an individual independent unit, like several different rooms in a hotel being separate rooms and not necessarily part of the same hotel, because they all have different capabilities. So cytokines are leukocyte derived. They are important in inflammation and in immune responses. And with this, we've been able to establish what is the positive and the negative balance. And the work that I'm going to present now is to do with one of my registrars. Actually, 3 of my registrars who've completed MDs and PhDs through them, and there are still 2 PhDs ongoing, so this process is still working. His job is on the work, is being done rather. So we talked about pro and anti-apoptotic genes, and looking at the endocrine tests, we have a list of the hormones that I've listed up at the top, which have a positive impact on the quality, or who positively correlate with developmental potential of the egg. But if you have progesterone rise before you give ACG, if you have high levels of androgens in the follicles of follicular fluid, if your estradiol testosterone ratio is reversed or cortisol ratio is reversed, you have poorer quality gametes. And the same thing is true for various growth factors. BMP15 I've already mentioned, IGF-1, 2, IGF-BP I've already mentioned, and then we have the inhibins and various other cytokines that we think are very important, positive predictors. And then there are negative predictors. The anti-Müllerian hormone and TNF-alpha definitely seem to suggest that these oocytes are poorer quality. Similar is true for vascularity, reactive oxygen species. And I've already mentioned that hypoxic follicles contain eggs with high incidence of abnormalities in the amniotic spindle, because hypoxia is bad for the cells and for cell development. And the same is true for the negative side as well. If you have hypoxic cells and all these superoxide dismutase and nitric oxide, nitrites, nitrates, etc. If all of these are raised, some of the endorphins, then you're likely to have poorer oocyte treat. These are some angiogenic cytokines that we've studied, and basically looking at the perturbation that occurs. This is a natural cycle. This is again one of my registrar studies. What she showed was in the red boxes is a very good correlation between the cytoplasmic and oocyte cytokines. And in the blue, here you have intermediate correlation, and the black was negative correlation, which means adverse effect. And what you see is that the pattern in the natural cycle is very different from that with controlled ovarian hyperstimulation. So when we are using gonadotrophins, we are not producing as good follicles as we do with natural cycles. And that's the crux of the message that we have to find treatment regimens which will produce multiple follicles that are as good as a single collected oocyte in a natural cycle. Same thing is true for fertilizable, and this is unpublished information, has just been actually submitted to a good journal. So it isn't peer reviewed yet, but what you see here is that the oocytes that will fertilize will follow a certain pattern, and the unfertilized and the fertilizable oocytes are clearly delineated. So natural cycle and stimulated cycle cytokines vary, and aging and angiogenesis is the important VEGF or vascular endothelial growth factor is very popularly used. In fact, its agonists are being used by ophthalmologists, antagonists are being used by ophthalmologists, and it also has application in, apart from retina, I know in various other fields, joint orthopedic people are using it as well. And it is progressively rising as women get older, or men get older, and that's because our angiogenesis capacity goes down. As the oocytes are reducing in numbers within the oocytes, the ovary becomes smaller, the vein volume goes down and the VEGF levels go up. And when the ovaries are less responsive and you need to use high-dose gonadotropins, then your VEGF levels go up. This is just an image of vascularity that you can monitor during IVF cycles, and again images taken by one of my registrars, which shows here that this follicle has very little vascularity, whilst this one has more than 75% of its circumference with blood supply. And this follicle is the one which is likely to give us a competent egg as compared to this one. So again, improving vascularity, but inflammatory processes we know, I'm sorry if I run a few here, but inflammatory processes we knew, and we know, such as endometriosis and polycystic ovaries, do compromise on ovarian vascularity, follicular vascularity, and when that is compromised, you have hypoxic follicles and poor quality eggs. So, VEGF is a good marker for hypoxia. We've learned that. That's enough. Younger women whose ovarian response is restricted and is similar to that of older ladies also have raised VEGF levels. So is it because they have a problem with vascularity per se? We don't know that. That's a question that some people need to take up and answer in research, but this is where we are with a question there. We also have ethnic variations, and what you will find interesting is that just looking at one group of cytokines and their polymorphisms, in this group here, you see that the Eastern Asian and Indian Asian women have higher cytokine levels of this variety as compared to the Caucasian and the Afro-Caribbean ladies. So that implies that our metabolic changes and our metabolic evolution process is very different at cellular level, at molecular level. We and ourselves behave differently from those of other groups. And this is where many of the works that are being done elsewhere have to be repeated in Asian populations. And not only have to be repeated, they are being repeated in Asian populations in the West, in Britain for instance they are, but then they're also based on the Indian population based in Britain who enjoy and live a different lifestyle and have a different nutritional status as compared to the Asian subcontinent here. And this is where I think repeat studies of this nature are very important in the subcontinent itself to see how truly they transpose from there to here. So just taking up any information from the West and applying it here would be inaccurate because of our ethnic differences. BMI is very important. It's a marker of inflammation. We know that if you have a BMI greater than 35, you have a 25% lower success rate. And this is because many of the inflammatory cytokines are sequestered within the fat cells, probably produced in the liver, and the inflammatory aspects, just showing the same thing, is obesity, a state of inflammation. Looking at different types of gonadotrophins, no difference. Looking at different regimes, low-dose stimulations are, people who are practicing reproductive medicine will know this, are being propelled and pushed as the panacea for success, but they're not. The studies are suggesting that they still have the same problem. And lowering LH or keeping LH within the optimum range with antagonist or agonist versus also do not show any differences, except that in high responders, the risk of ovarian hyperstimulation is reduced. So to conclude the scientific section, we have cytokine concentrations that vary in the natural cycles, they affect oocyte quality, and we have androgens. We have some of the other issues to do with poor responders. We start to talk about use of androgens because of their different roles, and I can always talk about that in private capacity with anyone who wants to. But just to say that they have great roles, and DHES or androgen therapy has had its interest raised in the West as well, but that's largely on theoretical grounds on the basis of these functions that are on this slide. And again, I can let you have them if you wanted them. But theoretically, they're supposed to increase the pregnancy rates, but there are no randomized controlled trials that show that there is evidence that this happens. So I can't sell it to you as a way of treatment. Androgens increase in rhesus monkey, they increase the IGF-1, which you would remember from my earlier slides is very important in the initiation of a follicle. And again, but it has not shown any evidence for benefit. No randomized control trials have been done yet, in fact, to show that there is that benefit. And the same is true for dexamethasone, and the same thing is true for melatonin. But I want to move on to thyroid function, which is increasingly recognized. 5 to 10% of women in childbearing age presenting with fertility problems in any gynecology clinic have underactive thyroids, and we perform thyroid function tests as a first-line investigation in all women, and its optimum treatment is very important. So what was previously thought to be optimum is no longer optimum, and these are the British Endocrine Society guidelines or recommendations, and what is being considered as optimum treatment is maintaining TSH below 2. The normal range is up to 4, but a TSH of 2 to 4 is not considered as optimum replacement of thyroxine in a hypothyroid person. But even in euthyroid women where thyroxine levels are normal but TSH is between 2 to 4, there are some practitioners who are suggesting the use of thyroxine. Again, this has not been in small doses, very small doses, 25 micrograms is what they're talking about. But it's very important to recognize that this is still a subject under discussion. It's being increasingly promoted, and we don't have yet randomized controlled trials to show that there's a clear benefit. And the same thing is true for vitamin D receptor as well. But 75% of Asian women, partly because of the covered up demeanor, but partly because we have less sunlight, and partly because we have colored skin. Colored skin filters out all the ultraviolet light, so we don't retain as much vitamin D, which is important. You would think it was only important for the bones, but it's really important for reproduction too. It is present in all the glands in the male and the female reproductive system, and its replacement is very important too. So again, this is being considered as a very important adjunct supplement, in addition to folic acid in preconceptual preparation of any couple who are trying to conceive. So effectively, what I'm saying here is that there are lots of individual variations. One size does not fit it all, and we have to find the right recipe for the right patient. So much about science. If we are running short of time, I can skip on regulation. I'll cut on that a little bit. Survival, we had VLA, we had Human Fertilization and Embryology Authority, very draconian to start with. We danced to its tune to start with. We became really upset. There was a lot of disquiet. HFA had to think back and decide on what it's going to do. It conducted a whole survey and defined what is the purpose of inspection. These are regulating bodies. So we have a statutory obligation. This is a Department of Health body. And HFA person responsible is responsible for the compliance with this law. I believe the Indian Parliament is considering passing a law, but we had ours passed in 1990. So this HFEA has to ensure that there is compliance in all the services. HTA, Human Tissue Act, is a similar law which is adapted from the European Union Tissue Directive, and CQC stands for Care Quality Commission. And their entire purpose is to ensure that the safety of services for the patients is maintained. CQC is very patient-oriented, patient-focused organization. So for the centres also, there must be positive learning in this, and there should be an opportunity to feedback, and the inspectors should provide, and the patients should receive independent professional perspective. The inspectors should be evidence-based, consistent, professional, courteous, focused on risk, provide value, and not hand-fisted, not draconian, but courteous. And that was the conclusion that HGT drew. They must make some commendations, they must appreciate where things are good, so that examples of good practice are passed on to the others, and that way the entire service across the nation improves. And we all do some things well and some things we don't do well, and we can all learn from each other, and that's the aptitude for all of this. So we have quite a lot of regulating bodies, as you can see: HFEA, CQC, CSU, ISO, Freedom of Information Act, Data Protection Act, HTA, everything. And there is a lot of inspection process that goes on. There is a self-assessment questionnaire that I have to complete every 2 years, where I have to go point by point for the law and say, yes, I comply with this law, and yes, I comply with this clause of the law. And it's effectively a statement, which means that I could be hanged if it's not hanged literally. Over 2 years imprisonment you can get. That's the maximum. If you are found to be non-compliant. So incidents, complaints, risk-based assessment tools, audits, they all form part and parcel of our daily work. They are not, so we're not just seeing patients, we're also measuring our own performance. And unannounced inspections were announced by the Department of Health. Initially there was a lot of disquiet. This happened about 4 years ago. And a lot of disquiet in the profession, because we thought, well, we really don't trust you. Are you here to catch us out and celebrate when we are caught out? Do you not trust that we are saying what we're doing? But at the end of the day, it has actually been a good tool. We feared certain upheaval, but there hasn't been any. We feared interruption and disruption to clinical activity, but there hasn't been any, because they insist that the service continues as normal and nothing is changed or disrupted. We wondered whether there will be a constant stress of preparation, but if you are constantly working to a regulatory system and are compliant, then you don't have a problem. And we thought we might have difficulty in training our juniors into the PR role, but we don't actually have that. It is certainly daunting for the PR, but how I've handled it is by looking at what is the patient perspective. Patients want good facilities, they want environment, they want parking. Most of all, they want a lot of time with the doctor. They want to understand, they want to be treated humanely, they want to be treated with respect, they want to be explained things. They want to see that our success rates are good, they want to have contemporary information about your practice, not one that is plucked from somewhere else, or one which is validated independently, and not one that they can't go and check and say, yes, you are telling the truth. So you don't get inflated success rates, and you don't end up paying loads of money. So that's what the patients want. As a result, we are very IT-oriented people. Private centres in our country also have PR companies and legal protection. We don't actually in the NHS require that. But basically it was a process of compliance and agreement and cooperation, where the big dog says, little dog, would you jump with me? And I say yes. And the small hand grows into the long hand with change. Governance is essential. We had professional failings in the UK whilst I've been practicing there since 1976. Organizational failings have occurred. Francis' report was produced a few years ago. It has many recommendations for how the NHS could improve its services to the patients. And I brought this in because one of my colleagues asked, or my Indian colleagues, my friends, class fellows, asked for comments on this article this morning in Indian Express, which I recommend you go and read, because it quotes a paper written by a professor, an Indian professor who works for British Institute of Tropical Medicine, and it's a very good commentary in the Lancet on Indian health system. And basically, it proposes that there is a wholesale change in attitude of the institutions and service provision on the part of the government and the service providers alike, and also in the attitude of the service providers as a doctor, as a profession itself. And we need to promise to learn and act, and it's all in the interest of changing the culture within the health service. You put patients first, you have to be transparent, you take responsibility for poor care, and very importantly, you learn from your mistakes, because there's nobody who doesn't make mistakes. Everybody does. We've all made mistakes, but we must learn from them rather than cover them up. And we must strive to do it better, improve, work better, and even if it's not broken. So again, how we do it is we ask the patient. We have a quality patient satisfaction questionnaire. It has many questions, something like 100 questions, so whilst we keep them waiting for the embryo transfer, we insist that they complete this questionnaire before they go for the embryo transfer. We build in half an hour wait into them. We don't tell them, but we build it into them so they can complete the questionnaire. And this is the size of our unit, so just to give you an idea of the number of people we treat, 1,500 to 1,800 IVF cycles a year, in addition to many laparoscopic surgical procedures and outpatient episodes. And we ask the patients to give us a score on many questions that we ask. And this score, you can see, we would measure as poor or good or extremely good, and we measure ourselves in patient size. We then monitor our trends, look at our complaints, the written complaints that we've received or verbal complaints that we've received. They're all logged in, and we look at the trend of those. We look at which areas we get them in, and we get the majority in the clinical section, which is to do with the doctors and the nurses, and how we either fail to give enough time or fail to explain or to conduct something right or proper. And this is very important to recognize that we are the ones which are most important in the patient's life, and we are the ones who generate most problems as well. So we log ourselves, we look at our trends, see if we are making improvements. We look at patient safety, we look at our incidents, and we look at efficacy. We'll see if our multiple pregnancy rate is going down whilst our success rates are going up at the same time and are not being compromised. And we monitor individual performance, so that we know that there is no black sheep in the team, which is bringing the whole service down. So we monitor each other's, not each of the unit monitors. This is, as a PR, I have a role to monitor confidentially, and this forms part of the person's appraisal, their success rate. So, and compare that with the rest of the team and the rest of the group and the rest of the group, so that they have an opportunity to learn, retrain if required. So the service also has key performance indicators, and we monitor all of this. You need to learn, speak, listen, and this is what the license is based upon. We are assessed for suitability to act as a PR. There's very little training. There are about 8 pages. A lot of it is common sense. A lot of it is really being on an assault course, jumping and diving when you have problems, managing them and dealing with them, and this is how you learn risk management. But we all have the capacity to do that, and that's important to recognize here. We can analyze, we can question, we can acknowledge, we can have motivational issues, we can have rationalization, we can sometimes use leverage. You do this for me, then I'll do this for you, and not otherwise. All this is part of the game to ensure that you actually do the job well. Yes, self-assessment questionnaire is a noose against which the PR could be hanged should you have a serious untoward incident. And yes, organizations move rather slowly, and the PR is left rather despondent, working late in the night. And yes, you sometimes come to the work with the world's burden on your head, and it is a precarious balance. You think your balls are going to be on the floor sooner or later, but we keep trying. We try to be prepared, we try to have a strategy, we try to engage all our key performers, people, key leaders. We strive constantly for improving process, and IT forms a very important part of ensuring that the team is involved. But this is really what I want to leave you with. We need to have a change in culture. So this is what we're talking about in Britain today. These slides were part of my talk as a person responsible at the British Fertility Society meeting this year, some of these slides. So if we are talking about these things today and you see the disparity that exists in medical services between here and in Europe, then just think about this is the evolutionary process that you have to absorb with courage and with conviction, and acknowledge that this is important. This is important, this is the way how things are going to move, and particularly I appeal to the young doctors of the future to understand that medicine is changing. You are a service provider. We have to work with the patients in the same direction. Thank you.
And a shawl of honor to her.
I convey my sincere thanks to Dr. Vinay Sharma for sparing her valuable time and give us a talk on a very important subject. The talk was highly educative and informative, and the topic was, of course, what India needs today.
Sukadam Varadam Mataram